Yes, sir.
All right. Good morning, everyone. My name is Albert J. I'm one of the faculty members here at the University of Washington in our Department of Orthopedics and Sports Medicine. I've been asked by our chairman, Dr. Chansky, who couldn't make it to the start of this grand rounds this morning, to introduce our grand rounds this morning. I have one announcement to make first before we start, however. I'd like to say congratulations to Kathy Vu and Corey Schiffman, who will be our administrative chief residents for the upcoming academic year. Congratulations to them. I'm not sure congratulations is in order. It's a tough job, but it sounds like they're up for the challenge, and I think they're very well equipped to be administrative chiefs this year. So congratulations to both of them. We have no other announcements to make this morning, so we'll get started right away. This is the grand rounds for July, and we have the distinct pleasure of having one of our residents and one of our faculty members presenting today. First, we'll have Dr. Jay Yao, one of our fourth-year residents, start us off. The talk today is going to be on massive and irreparable cuff tears, the state of the art, and the faculty member with us this morning is Dr. Jason Hsu, who's a great friend of mine and colleague. He's the Rick and Ann Matson Endowed Professor in Shoulder Research, and he's one of our associate professors, here in the Department of Orthopedics. So we're very fortunate to have both of them, and we look forward to your talk. Thank you, guys.
Thanks, Dr. G. I'm going to share my screen.
Go ahead, I'll duck out.
Can everyone see these slides?
Looks good, Jay.
Okay, let's get started. So good morning, everyone. Thanks for your time. I'm really honored to have this morning to present with Dr. Hsu. Our topic for Grand Rounds today is the management of massive and irreparable cuff tears, state of the art. I have no relevant disclosures related to this talk. So for today, I'll be spending the first part of the talk discussing what is a massive cuff tear, factors associated with a tear that may make it more likely to fail with repair, and the presentation of workup of patients with massive irreparable cuff tears. After that, I'll turn it over to Dr. Hsu for discussion of treatment and management of these patients. So the definition of a massive cuff tear still remains a piece of variability within the literature. It's well known that this entity or family of disorders known as massive tears are challenging to treat. I think it's worth spending some time reviewing the rotator cuff tear pathology and the different definitions of a massive tear that exist. So I think we're all familiar with the four muscles that make up the rotator cuff: the subscapularis, supraspinatus, infraspinatus, and teres minor. And these muscles have a very complex anatomy and mechanics, but the function of the cuff, I think, can be primarily reduced to three major roles. The cuff allows for rotation of the humeral head within the glenoid. The changes in the effective point of force application as the position of the humerus changes. The cuff compresses the humeral head into the glenoid. This concavity compression is critical for shoulder stability, and when it's compromised can lead to a loss of stability, including humeral head escape. Additionally, the cuff has to balance the force couples across the shoulder joint. And so as an example, the inferior cuff has to balance the moment that's created by the deltoid. And so loss of cuff function and health can lead to dysfunction in regards to movement, stability, and balance across the shoulder joint. And while there are traumatic tears, our talk is primarily focused on degenerative chronic ones. Previously, the pathogenesis of atraumatic chronic cuff tears was theorized to be a result of extrinsic compression. However, this hypothesis is less likely to be true. Rather, it appears more likely that microtrauma, degeneration, oxidative stress, and other changes intrinsic to the cuff play a larger role than so-called extrinsic factors such as acromial pathology or impingement. An explanation focused on extrinsic compression does not really explain the articular-sided tears that can be seen in the rotator cuff. Furthermore, recent systematic review from this institution found that there was really little evidence to support the theory of subacromial decompression leading to common forms of cuff disease. And so our current understanding is that as the cuff tendency load, individual units or fibers within the tendon may fail due to microtrauma, age-related degeneration, oxidative stress, and other intrinsic causes. As these fibers fail, the adjacent fibers experience low concentration as the size of the insertion decreases, the overall strength decreases, and changes to the local morphology may affect the blood supply, leading to local ischemia. These can lead to weakening of the cuff, loss of function, and inability for the cuff to properly heal. This eventually can present macroscopically as atrophy, tendon retraction, and fatty infiltration of the cuff. A lot has been written about the anatomy of the cuff. Of note is the rotator cable crescent concept. The rotator cable is a thickening of the cuff, which some have hypothesized may stress shield the rotator crescent, which is a thinner area. Most tears appear to start within this rotator crescent and may remain stable because of the loaded cable that forms like a suspension bridge. However, eventually these tears, when they propagate, can violate this construct and be no longer stable, involving multiple tendons. So individual cuff tendons can and do tear, but massive cuff tears are a slightly different entity. I think they're distinctive not just in their size, but also in the poor outcomes and management challenges that they present. Unfortunately, there's still a bit of variability in the definition of what defines a cuff tear as a massive tear. So earlier reports, such as this one from the Mayo Clinic, defined massive cuff tears as over 5 centimeters in size. In this study of 105 chronic cuff tears, they defined 11 of them as massive, which is only 10% of their cohort. They used a size of 5 centimeters. They found that tear size was related to outcomes, particularly massive cuff tears were found to have poor outcomes after surgical repair. It's worth noting that the correlation between cuff size and outcomes remains somewhat murky, given more recent work. Some have criticized the use of an absolute tears repaired in Zurich. Instead of using a 5 centimeter cutoff, they defined massive tears as 2 tendons or more. Their endpoints were clinical and MRI follow-up. The re-tear rate on MRI was high, with 10 out of 27 having a re-tear, and they also found that fatty degeneration on MRI was not reversed after repair. And this is a key theme to keep in mind when evaluating massive tears, as the amount or degree of fatty infiltration may be a poor prognostic indicator. So when looking at cuff tears, the supraspinatus has been shown in multiple studies, including these 3 here, to be the most frequently involved. And in these cuff tears, a proportion of patients will have concurrent tears of the infraspinatus. And so using the 2 tendon definition, the prevalence of massive cuff tears may be higher than previously reported. A more recent study out of Japan has expanded our understanding of the anatomic relationship between the supraspinatus and infraspinatus. So in this study, they dissected 113 shoulders and 64 cadavers and found that, contrary to previous belief, that the infraspinatus insertion at the greater tuberosity is more substantial, superior, and anterior than previously believed. And so many isolated or thought to be isolated supraspinatus tears may also involve a portion of the infraspinatus. Here on the left, you can see what has traditionally been thought of as the supraspinatus footprint in pink and the infraspinatus footprint in purple. What they found instead on the right was that the infraspinatus footprint is much larger than previously thought, and it may actually provide more than just external rotation, but significant elevation power as well. So recent work has been done to try to subclassify massive cuff tears. Colin and co-authors looked at 100 patients with stage 3+ massive cuff tears and looked at the specific tear patterns. And they defined 5 types of cuff tears. I apologize, this is probably slightly difficult to understand at first glance, but we'll go through it. So each of these bars represents a different portion of the cuff. And so this bar is the supraspinatus, infraspinatus, teres minor. And they separated the subscap into the superior and the inferior subscap. And so a type A tear would be one involving the supraspinatus and the superior subscap. Type B, supraspinatus and the entire subscap. Type C, supraspinatus, infraspinatus, and superior subscap. Type D, supra and infraspinatus, and type E, supra, infra, and teres minor. And so they looked at active range of motion as their primary outcome, trying to correlate the pathology that was seen on MRI with a physical exam. And interestingly enough, if you look at all 5 of these groups, when it comes to pain, there's really no significant difference. And so tear pattern within this cohort of massive cuff tears did not seem to predict how much pain patients would have. However, there was a stark effect seen when looking at pseudoparalysis. And so you can see in the type A group, none of those patients presented with pseudoparalysis, whereas in the type B group, over 80% of them presented with pseudoparalysis, and type C and E also had a significant portion, whereas type D had almost no patients with pseudoparalysis. I think not surprisingly, the active range of forward elevation mimicked this. And so what they really found, I think, to sum it up, is that dysfunction of the entire subscap and supraspinatus or 3 cuff muscles may be associated with pseudoparalysis, which is important for our clinical understanding of these patients. So what is a massive cuff tear? I think for the purposes of this talk, we can probably accept both definitions of either 2 or more tendons or over 5 centimeters of tearing is valid. But I think we should caution that because of this variability, there's some variability within this group of patients with massive cuff tears, and it's more likely to be a heterogeneous family of pathology rather than a distinct, precise clinical entity. That means they can have a variable presentation, which may include something like pseudoparalysis. Also, we're focused primarily for this talk on what is the chronic group of patients. Although you can have acute and acute on chronic massive cuff tears, our focus is really on degenerative chronic tears. So what makes something quote unquote irreparable? I think, again, this is hard to define. Technically, you can repair anything. But what we really want to know are the characteristics that might dispose someone to have an unacceptably high risk of repair failure. So when looking at risk factors to re-tear, I think one of the biggest and most important to remember is age. So this is a paper out of WashU and AJSM looking at 49 shoulders with a 1-year minimum follow-up. And they found, looking at re-tear as their primary outcome, that age was associated with lower rates of healing after cuff repair. And so you can see here in their analysis that the patients who didn't heal were on average older than those who healed, about 63 years old in the non-healed group, and 55 in those who healed. And of course, the number of tendons involved also exerted an effect. Even on multivariate regression, this relationship held. So in addition to age, the amount of fatty infiltration has been thought to be a predictor of cuff healing. Probably the most well-known way to quantify or try to objectively understand the amount of fatty infiltration is the Gutalier classification. So this is described originally in 1994 in CORE. These authors used CT scans as their imaging modality. This was revised by Fuchs and others from Zurich to be more applicable to MRI, and I think probably this is now the more common modality that's used for non-arthritic patients with cuff disease. So the Gutalier classification, just as a review, uses the amount of fat on MRI and the cuff musculature as its dividing point. And so stage 0 lesions are essentially normal muscle with no fat. Stage 1 lesions, as can be seen here on the left of this diagram, have fatty streaks, but these are rare and do not appear to be clinically very important. Stage 2 lesions have significant fatty infiltration, but there still remains a predominance of muscle, meaning that the amount of fatty infiltration is less than 50%. Stage 3 lesions have equal amounts of fat and muscle, and stage 4 lesions have more fat than muscle. So recent meta-analysis of factors associated with re-tear after cuff repair have found a number of factors to be associated with re-tear. As previously mentioned, tear size was associated with an increased odds of having a re-tear. Fatty infiltration, again, was found to be associated with a higher risk of re-tear, whether it was fatty infiltration of the supraspinatus, infraspinatus, or globally throughout the cuff. And as mentioned previously, age was an important factor. So in addition to fatty infiltration, these factors, Meyer and co-authors also looked at the role of tendon retraction, particularly the supraspinatus. So they conducted a retrospective review of 33 patients, or 33 shoulders, excuse me. So on preoperative MRI, they determined the Gutalier classification, the amount of tendon retraction as could be measured on MRI. And their primary outcome was repair failure on postoperative MRI. And what they found was that tendon length seemed to be a key contributor to repair failure rates in addition to the amount of fatty infiltration. So just to look at these figures, so what you can see here on the left is that as the amount of fatty infiltration increases, the failure rate, which is the percentage here above the bar, goes up with progressive amounts of fatty infiltration. I think more interestingly, when they separate the patients out by the amount of tendon retraction within these groups, they found that a tendon length less than or equal to 15 millimeters was associated with a high failure rate. So you can see here in the Gutalier 0 and 1 patients that patients who had a tendon length of less than 15 millimeters had twice the risk of re-tear or failure compared to those with a longer tendon. Similarly, in the Gutalier stage 2 and 3, it's a 3 times difference between those who had a shorter tendon and those who had a larger one. And I think probably it's worth noting it's not just really the length of the tendon that's important, but length of tendon may actually be more a proxy for tendon tissue quality. And so while fatty infiltration is important, if the tendon is not retracted or has some residual structural quality, perhaps we might be a little more optimistic, as can be seen on the right side of this figure. So I think we've defined what is a massive cuff tear, and we've just discussed the characteristics or risk factors for failure repair, which would include a high amount of fatty infiltration, tendon retraction, or poor tendon quality, and other patient characteristics, which include things like age. I think the last thing I'd like to do before turning it over to Dr. Xu is to briefly review the presentation and workup of these patients. And some of this I think will be repeated material. So one important thing to realize is that in addition to evaluating the shoulder, it's important to evaluate the whole patient that is attached to that shoulder. And so this is one study from the Moon group looking at 393 shoulders with atraumatic tears that were treated through PT, and they classified them by cuff disease severity. And so they used the pain scores that the patients had as their primary outcome. And interestingly, they found that the tear characteristics were not really correlated with the pain. Rather, it was their comorbidities, their education, their race, and other social factors that seemed to be more strongly correlated with patients' pain. I think this may not be too surprising to some people, I suppose, if you understand that pain is a complicated response and that there are things that affect it outside the shoulder, but function may also be affected. So this is a paper by Harriman and colleagues looking at 333 shoulders with full thickness supraspinatus tears and looking at a variety of patient characteristics. They're looking at function. And so they found that, in addition to supraspinatus tear, having an infraspinatus tear was linked to patient's function. But they also found that medical and social comorbidities were negatively correlated with outcomes. So I think everyone agrees that taking history is important, but in the setting of massive cuff tears, I think especially we need to be very careful to understand the progression of the patient's symptoms, the nature of their symptoms, and additionally the factors extrinsic to the shoulder. There's a variety of exam findings and tests relevant to the rotator cuff. I think in the interest of time and knowing our audience, I won't review these in detail. However, one thing that's worth noting is that there's been some suggestion that simple exam findings, such as a hornblower or a dropping sign, may actually correlate with the amount of fatty infiltration and could be considered pathognomonic. So this is a French study on 54 patients who were operated on for supra and infraspinatus tears. And they found that a hornblower and dropping sign was correlated with stage 3 or 4 changes, and they cited a sensitivity of 100% and a specificity of 93 to 100%. So like stated earlier, I think when looking at a patient's active range of motion or patients with pseudoparalysis, it's worth considering how their range of motion may match the MRI findings of what tendons are torn and involved. Just as a review, it's really these type B patients who are at a really high risk of pseudoparalysis, and C and E, of course, also have a substantial risk as well. I think we've discussed some of this already, but it's worth reviewing the imaging. Plain x-rays are still incredibly helpful, I think, in the clinical evaluation of these patients. You can look at the acromial-humeral interval to look for subtle escape that may not be obvious on first glance. Additionally, I think what we really want to know is if there's significant arthritis, as this can change our treatment algorithm. And we've already reviewed the Goutallier classification. Just as a review, it's stage 0 would be no fatty infiltration. Stage 1 would be just streaks. Stage 2 would be less than 50% of the muscle is infiltrated with fat. Stage 3 would be equal amounts of fat and muscle, and stage 4 would be more fat than muscle. So in imaging, what we're really looking for are arthritis, tendon retraction, muscle atrophy, and fatty infiltration. So just as some conclusions to conclude my part, we can define a massive cuff tear as a defect over 5 centimeters or 2 or more torn cuff tendons. Factors that may lead to cuff repair failure would be a high amount of fatty infiltration, stage 3 plus, tendon retraction, poor quality, and patient risk factors and characteristics such as age. And then the presentation of workup of these patients involves a careful history, taking into consideration the whole patient, understanding their range of motion and looking for the presence of pseudoparalysis, and appropriate imaging, which would include x-rays and cross-sectional imaging. So these are my references. Thank you for your time, and I'll turn it over to Dr. Xu. Thanks.
All right. So Jay, thanks for the great presentation. That was a great review and background of massive and what we might consider functionally irreparable cuff tears. So I'm going to talk more about the management options and the latest on what's out there for treatment of these massive and irreparable tears. So these are my disclosures. I do have a relevant disclosure to this talk. One of the options I'll discuss for irreparable cuff tears is reverse arthroplasty, and I do work with DJO on the design of these implants. Before I get started, I just wanted to emphasize the great work that Jay has done in his academic pursuits. He's been prolific during his couple years here, and the work that he's done with our shoulder group has really been stellar. And it's not really common that you have a resident that has as many publications as he does. So I just wanted to highlight his great work. So my objective is to discuss the treatment and management options for irreparable cuff tears, and I'll outline treatment options, and then I'll also work through one potential algorithm that you can use for treatment of these tears. Some of these are investigational treatments, not necessarily a lot of supporting data, but it's good to know what's out there. So orthopedic surgeons are known for trying to keep things simple, and when it comes to treatment algorithms, we do like to keep things simple. So this is a back of the napkin algorithm that one of my previous co-residents had recommended, and it would be super nice to have something simple like this, but as many of you that have treated rotator cuff problems know well, when it comes to anything related to the rotator cuff, nothing is really this straightforward or simple. So I'll present a general algorithm that I'll use, and unfortunately it'll be a little bit more complex just because there are so many variables to consider related to the patient and the characteristics of a tear that make it a little bit more complex. But I'll try to keep it simple, and I'll use a case-based presentation to outline the treatment options and how they fit into this algorithm. So we'll start with this case. It's a 71-year-old female. She's had an increase in pain over the last couple of months after an overseas trip. On exam, she has painful elevation to about 120 degrees, has weak thumbs down abduction, negative belly press, and on her MRI, you can see that she has a full thickness tear of both her supraspinatus and infraspinatus with some mild atrophy. So the big question here is, in this 71-year-old with a 2-tendon tear, should this tear be repaired? And so Jay kind of went over some of the data related to this. About 30 years ago now, Drs. Harriman and Madsen reported on about 100 rotator cuff repairs, and they were really one of the first to show that rotator cuff repairs don't always stay intact. And so they used ultrasound and found that in repairs in which when more than just the supraspinatus need to be repaired, over 50% of them retore, and age and size of the tear were the most important factors. And more recently, the group out of WashU reported that even using contemporary arthroscopic double row techniques, that the majority of massive tears retore. And the interesting thing here is that despite re-tearing, the majority of the patients that retore still had high ASES scores. And this really suggests that there's something more to just the structural aspect of the surgery that led to good results, and that fully intact rotator cuff isn't really necessary to have a well-functioning shoulder. And Jay also went over the systematic review that was done by Dr. Madsen and Dr. G, looking at rotator cuff repair failure, and found that tear size, muscle atrophy, age, all are significant risk factors for re-tear, which, if you remember, the patient that I presented had. So conservative management may just do fine in these patients. We can focus on gentle stretching to help resolve any capsular stiffness, and then the exercises here involve mostly active assist exercises like active assist forward elevation and some external rotation stretching. And then once the range of motion is maximized and any capsular stiffness is resolved, the patient can start on some cuff and deltoid strengthening. In particular, we try to focus on the anterior deltoid strengthening and retraining this muscle so it can compensate. This is particularly helpful for patients with large tears. And then we can also work on internal and external rotation strengthening, which can help to maintain the muscular balance of the shoulder that Jay described earlier. So this is an important study to know about, which was reported by the Moon Shoulder Group. And they followed over 400 patients with full thickness tears and treated them conservatively with PT over the period of 2 years to see what proportion needed surgery and what the reasons for needing surgery were. And they found that only about 20% of this cohort needed surgery. One of the important points of this paper is that the expectations regarding the effectiveness of conservative treatment and physical therapy was more important than the symptoms that the patient had or the structural or anatomic features of the tear itself. So if you look at this figure, the patients that had a score of 5 for expectation, so the higher score here is that you have higher expectations that PT would work. And if you look here, you can see that there's a direct correlation of surgery-free survival and expectations, with a higher percentage of those with high expectations for PT not needing surgery, and then less than half of those with low expectations being surgery-free by 2 years. So one of the big questions is whether this is a modifiable factor and whether you can convince a patient that PT will work and change their outcome. And I think most people would think that this is a modifiable factor. And this was an interesting systematic review looking at psychosocial factors in the management of cuff tears. And the data really suggests that psychosocial factors significantly influence the level of pain and disability that these patients experience. And there was a direct relationship between patient expectations and outcomes. And so when explaining the treatment options to the patients, the way that you explain the options and the probability of success is probably very important. And this is the case with pretty much every orthopedic issue that we treat, but more so with a rotator cuff, how positive you are and how you shape the treatment option with the patient may have a direct impact on how they do. So going back to this patient presenting with 2 months of pain and an MRI showing a 2-tendon tear, she was treated conservatively, and by 2 months she had full motion and minimal pain. She's now 5 years out from her original presentation, is doing well with full motion. She's resuming all of her desired activities and hasn't needed surgery at all. So the first part of this algorithm is really focused on non-operative treatment with physical therapy, which should really be the first line of treatment for the majority of these tears. And many of these patients can have a good outcome with conservative treatment. But the physical therapy approach isn't successful for everyone. And so for me, the next decision branch is whether the patient has arthritis. And this may be pretty obvious, but if the patient has arthritis, we're looking mainly at arthroplasty options, including CTA hemi if they have well compensated motion and an intact coracoacromial arch, which I'll kind of describe later, or reverse shoulder arthroplasty for those that are more pseudoparalytic. These are really outside the scope of this talk, and we're going to focus primarily on patients that present with large tears that don't have arthritis. So in a patient with a massive or irreparable tear with no arthritis, the exam plays an important role, and we want to know whether the patient is able to compensate for their tear appropriately. So despite having a 2-tendon tear, many patients can actually use their anterior deltoid to compensate for the lack of strength. And so here's a case example of a very active 61-year-old who presented to me after having 2 previous surgeries, attempting to repair the rotator cuff, and presented for a second opinion because after a second cuff repair, they ordered another MRI, which showed a failed repair. And this was a second opinion on whether she should get a superior capsule reconstruction or reverse total shoulder. And on exam, she had retained elevation, but what was really notable that she had audible crepitus, and you could hear grinding and popping when she elevated and rotated her arm, particularly in abduction. So the question here is, should we be doing a superior capsule reconstruction in her, or should we consider reverse, or are there other options that we can consider? And so to answer that question, it's important to understand the concept of the humeroscapular interface, which was described by Dr. Matson. And if you think about the shoulder, we're often thinking about the articulation between the humeral head on the glenoid, but it's important to understand that this motion interface between the proximal humeral convexity and the coracoacromial arch is very important. So in the native shoulder, the rotator cuff naturally rotates within the proximal, the rotator cuff and the proximal humeral convexity rotate within the concavity created by the acromion in the coracoacromial arch. But in many cases, particularly in patients that have had previous surgery, there are adhesions, there are sutures from previous surgery, maybe prominent suture anchors, and all these things can prevent smooth motion at this humeroscapular interface. So the smooth and move is a procedure that Dr. Matson described, and this involves a few different things. So, doing a manipulation or capsule release to resolve any capsular stiffness, taking care of any biceps problems, because usually there is a subluxed or partially torn biceps. And then the important part here is removal of adhesions, sutures, or anchors in the humeroscapular interface, and making sure that the proximal humeral convexity is smooth again. Because oftentimes with rotator cuff tearing, you have an exposed tuberosity that's prominent. And it's really important in these patients to preserve the coracoacromial arch so we do not take down the CA ligament. We clean out this interface, and then immediately after surgery, the patient can start moving with physical therapy. And this is as opposed to rotator cuff repairs or tendon transfers. In those patients, you really have to give them 2 months of immobilization, whereas in this procedure, you can start having them move right away. So in this patient that I talked about, the 61-year-old active female, this is her arthroscopy photos. You can see a lot of suture and prominent anchors within her subacromial space that was probably responsible for the audible crepitus. And so the procedure here again is to free up the humeroscapular interface by removing all the sutures, the suture anchors, and then using a burr to burr down the tuberosity. And so we started her moving essentially immediately after the surgery. At her 2-week follow-up, she had full motion. She didn't use any pain medication after this operation. And she's now 4 years post-op. She hasn't needed a superior capsular reconstruction or reverse, and she's back to all the activities that she enjoys doing. So we reported on about 150 patients with compensated cuff tears and found that the procedure was both immediate, it provides immediate results and durable results. So at 6 weeks post-op, the majority of these patients have a significant improvement in their range of motion. And then we also reported an over 7-year mean follow-up and found that the revision rate was fairly low at only 5%. And the majority of these patients, about 70 to 75%, had a simple shoulder test change of more than 2, which is the minimally clinically important difference. So there have been some other groups. Dr. Matson described this originally, the smooth move as an open approach, but there have been a couple groups in Europe that have taken a similar approach and have done this arthroscopically and termed it the reversed arthroscopic subacromial decompression. And if you look at their indications, very similar. Patients that have some retained active motion are able to compensate for these tears. Those who didn't show improvement with in mobility and pain with physical therapy were considered poor candidates. And then in terms of the technique, it's very similar, taking care of any biceps pathology, any capsular stiffness, and then debriding the rotator cuff and doing a tuberoplasty and ensuring that the CA arch was not disturbed at all. And the results are very similar to what we've seen. And so these are the 12 questions, the simple shoulder test, and you can see that there's significant improvements in the majority. So again, to review here, the smooth and move is the indication is those with a irreparable cuff tear with preserved active motion and intact CA arch. And the technique is could be done either arthroscopic or open, and involves either a capsule release or a manipulation, a potential bicep procedure, and then clearing the humeroscapular interface with immediate post-op range of motion. So in our algorithm here, if you have a well-compensated shoulder with an intact CA arch, then this smooth and move or reversed subacromial decompression is a good option. I'll talk a little bit about more of an investigational thing called the subacromial balloon. I'll just bring this up. I haven't done this before, but this is something that's coming out in the United States soon. So again, this is an investigational device, and what this is an arthroscopically deployed PLLA balloon. And this is a video that one of Dr. Matson's previous fellows, Samar Hassan, took while doing this procedure. And the goal of doing this is really, if you put in this subacromial spacer, the thought is that it'll depress the humeral head and it'll improve deltoid efficiency and glenohumeral kinematics. And so it's coming here in the United States pretty soon, and it has been used in Europe for about 5 or 10 years. And there have been a few biomechanical studies on it suggesting that it can restore intact state glenohumeral contact pressures and lower the humeral head and maybe increase the deltoid load. But we're going to have to keep a close eye on the data that comes out with this. And so this subacromial balloon is essentially adding a subacromial spacer to the smooth and move procedure. And just like the smooth and move, it requires the patients to have an intact CA arch to contain the spacer. So, but what about patients that have weakness and they aren't compensating as well? And so this is probably the most challenging group, where these are usually younger patients that are more active. And so my approach to these patients is that, short of a reverse arthroplasty, the only way to regain function and strength is to somehow connect muscle, whether it's native or transferred muscle, to back to the tuberosity to recreate the function of the cuff. And so, depending on the features of the tear, this can either be trying a partial repair or doing a tendon transfer. And so here's an example of 39-year-old young guy, security guard, had multiple injuries through military service and had previous surgeries, including a rotator cuff repair. Now has pain, weakness, and a feeling of instability of the shoulder. And so he had poor forward elevation. His exam was positive for a positive drop arm test, some external rotational weakness as well, and actively could not externally rotate past neutral. And his MRI showed a pretty large rotator cuff with some atrophy. So you can see here the tendon is retracted to the glenoid, and then on the T1 sagittal, you can see the fatty atrophy includes the supraspinatus and the infraspinatus here. And so when we go through the options here, there's so many options that we can consider. And after failing conservative management, in this case, because he's not well compensated, the debridement or smooth and move procedure is not going to be probably a great option for him. And then he's a little bit too young to consider any kind of shoulder arthroplasty. So you have all these other options here with partial repair or tendon transfers to consider. And I'll present two options, which are my preferred options for these patients, which is either attempt at a partial repair or a lower trapezius transfer. And so the big question is, when should you attempt a repair versus doing a tendon transfer? And so if you have a patient with a supra and infra tear that has weakness and is relatively young and active, I like to figure out on the T1 sagittals whether there is, infraspinatus atrophy. And oftentimes these patients will present with an increase in pain, and the goal here is to figure out whether this is more of a completely chronic thing or whether it's acute on chronic. So on this T1 sagittal, you can see the supraspinatus is atrophy, but the infraspinatus is not. And so this is where I think you could consider a partial repair. So this was a fun study that I did in residency, and so oftentimes I spent a year doing research in a lab looking at the rat rotator cuff model. And so what we did in this study was we created chronic supra and infra tears, and we essentially took down the supra and infraspinatus on a rat, which the anatomy is very similar to a normal human shoulder. And so we divided them into three groups. We did a no repair sham surgery group. We did a partial repair where we only repaired the infraspinatus, and then we did a full repair of the infraspinatus and supraspinatus. And then we did a gait analysis. And interestingly, if you look at the gait of a rat, that's essentially equivalent to looking at the human shoulder function. So very interestingly, what we found was that if you look at the kinematics or the kinetics of or do gait analysis of the rat, that down here in the blue line here, this is the rats that had sham surgery and no repair. And then the red here is where we repaired the infraspinatus only. And then the green here is where we repaired both tendons. You can see that, whether you repaired both tendons or just the infraspinatus, the kinetics of the gait analysis was very similar. And this supports what Jade referred to earlier. The rotator cuff force couple is important. If you have a balanced anterior and posterior rotator cuff force, that usually there's a lot of compensatory deltoid function that can produce normal function in the human shoulder. And so clinically, there's been a few studies on partial cuff repair, and overall these studies have shown that these patients can be very satisfied with the procedure. They will get significant improvements in strength and range of motion. This is the most recent one that was published, looking at a comparison of a complete repair where they aggressively released as much muscle and tendon as possible to get the tendon over to the tuberosity, versus just doing a partial repair alone and not doing aggressive releases. What they found was that in terms of pain and functional outcomes and range of motion, they were similar between the two groups. But the interesting thing is that if you look at the follow-up and the re-tear size, it was much higher, much larger in the complete repair group. And that's oftentimes if the tendon pulls off, if you've done a complete release of the rotator cuff, that you're more prone to having a larger re-tear. And so it may be, advisable to do a partial repair rather than trying to release as much muscle as possible when you're doing these repairs. So partial repair can be considered in those that are acute on chronic tear, specifically if the infraspinatus is not atrophied. But if you have a chronic tear where both the super and the infra are atrophied, then this is when we usually consider tendon transfer or arthroplasty. So this was kind of a classic treatment for consideration of tendon transfer for these irreparable tears, and it was described by Christian Gerber probably 20 or 30 years ago. And so this is through a posterior approach, and they would find the latissimus off the medial humerus, and then they would reroute that over to the greater tuberosity and attach that to the greater tuberosity so that it could function more as an external rotator. The issue with this is that the native insertion of the latissimus, it acts as an internal rotator and an adductor. And after you transfer it, it needs to then become an external rotator and help an abduction. And so this is what we consider an out-of-phase transfer, and it really requires a lot of therapy and to retrain the latissimus as an external rotator. And a couple studies have shown that it's not always possible to get this latissimus to be what we call in phase, where it acts as an external rotator and abductor, and it's a variable finding. And so the latissimus is considered an out-of-phase transfer. And more recently, we've been looking at the lower trapezius as a potential muscle for transferring. And because if you transfer the lower trapezius, it's considered in phase. So you can see here that the direction of pull, if you transfer the lower trapezius, is more in line with the infraspinatus, where the latissimus is more of an inferior pull rather than the kind of external rotation pull of the native infraspinatus. And so biomechanical studies have shown that the moment arm is in a better position. The lower trapezius is in a better position than the latissimus for external rotation. The one thing that you do need to know about the lower trapezius transfer, that it doesn't span all the way to the greater tuberosity, so it does require a allograft, and we usually use Achilles tendon allograft. So currently we do this procedure arthroscopically assisted, and so this is kind of just a depiction of what we usually do for this procedure. And so we find the scapular spine and body and find the lower trapezius origin, which inserts on the medial 3 to 4 centimeters of the scapular spine. And there's a fat triangle near the tendon insertion that helps identify the insertion. We then detach and mobilize that tendon away from the underlying infraspinatus fascia and separate it from the middle trapezius. And then we take the Achilles allograft and we attach that to the greater tuberosity arthroscopically. And then we split the rest of the Achilles allograft and then do a pulver-taft weave through the lower trapezius to complete the repair. And we have the arm in external rotation while we tension this so that it can act as a good external rotator after surgery. And so we've modified this technique a little bit. So you can see in this patient that I presented earlier, the 39-year-old with a posterior superior tear, we've really burred down the tuberosity quite a lot. And so that allows the thickness of the allograft to be somewhat continuous with the rest of the proximal humerus. And then we use locking stitches on what will end up being the undersurface of the tendon, and use 4 knotless suture anchors to pull the tendon down onto the tuberosity here. And with this configuration, it allows the Achilles allograft to be pulled down onto the greater. And when the final construct is complete, there's no intervening suture between the graft and the acromion. And the goal here is, going back to that humeroscapular interface, that interface will be free from any suture or any rough surface. So this patient again had a big posterior superior tear with atrophy of both the supraspinatus and infraspinatus, and he's done very well in terms of at 3 months he's already has full elevation and regained external rotation strength. So outcomes after lower trapezius transfer in general, there's not that much data out there quite yet, but This is one of the studies looking at arthroscopically assisted lower trap transfer, and pretty much you can see improvements in all the, pain, range of motion, and patient-reported outcomes. There haven't been any comparative studies quite yet. But so taking a look at, these patients with that are younger and have some weakness and higher expectations after surgery, if it's acute on chronic where the infraspinatus has some atrophy, has no atrophy, then I think a partial repair is a good option. Whereas if it's really chronic where the supra and infra are both atrophied and retracted, then we consider the lower trapezius transfer, and classically it was described more as latissimus, but I think the lower trapezius has better biomechanical characteristics to it. I'll talk briefly about the superior capsular reconstruction because it really is a hot topic now and it's being performed a lot. I don't think we perform many of these at our institution, but it's good to know about. So Dr. Mihata originally described this over maybe about 10 years ago now. And what the superior capsular reconstruction is essentially taking either autograft or allograft and spanning the defect between the glenoid and the greater tuberosity. So he originally described this in 24 shoulders using a fascia lata autograft. And in his original report, they saw significant improvements in range of motion, an increase in the acromial-humeral distance from 4 to 8 millimeters. And this really has taken off, and it is really a kind of a hot procedure these days where there's been thousands done, probably 20,000 done in the past year or two. And if you look at PubMed on superior capsular reconstruction, the number of publications on this, I mean, there's probably been 150 to 200 in the past 5 years with very little clinical data. It's mostly biomechanical or review data. And if you look at a lot of the, clinical data, it's really, just subsets and cohorts of the original surgeon's experience. So there is some more clinical data coming out now, which is good to see. But I think this procedure still needs a little bit more data. Here in the United States, the superior capsular reconstruction, we are using human dermal allograft. So you can see here in this arthroscopic picture from the lateral portal, you can see the glenoid and the humeral head here in the retracted cuffed hair. And so we use human dermal allograft, and we shuttle that through and anchor it both to the glenoid and then to the greater tuberosity. So I think the data is still pending on this, and whether or not this is better than any other procedure that we do, I think it's still questionable currently. So what about irreparable subscapularis tears? That's a different problem that we have to address. So here's a example of a 41-year-old that has had a failed subscap reconstruction. He had a subscap tear originally working as a police officer, and then had an attempted subscap repair with allograft reconstruction 5 or 6 years ago. Felt a pop, and about 4 months after surgery, when he was working with physical therapy and on exam, had poor elevation, a lot of pain, positive stomach compression and lift-off tests. And you can see on this MRI here, he's had an attempted reconstruction. His subscap is no longer connected, and he has pretty much complete atrophy of the subscapularis. And so classically, the pectoralis major has been described as a transfer. So you can see here, this is a left shoulder. You can see the humeral head and the bare lesser tuberosity. You go distally, you can find the pec major tendon, release it from its insertion, and then it's been described as either just moving and transferring it up to the lesser tuberosity, or actually moving it under the conjoint to improve the vector of the pec tendon. But one thing to note, if you look in the axial view, looking here at the humeral head and its relationship to the pec and the subscapularis really, its main function is as an internal rotator. And if you look at the vector of the subscapularis and compare it to the pectoralis, even if you transfer that pec under the conjoint tendon, the vector is still a bit off to act as a good internal rotator. And so more recently, there's been a description of using the latissimus to treat irreparable subscap tears. I described earlier using the latissimus as an external rotator, which is not great because it's out of phase, but latissimus transfer for irreparable subscap is a pretty simple procedure that if you think about the direction of pull of the latissimus, it would act better as an internal rotator than the pec major tendon. And so here's a procedure that we did on that patient. So it's a standard deltoid pec approach. We've released the upper centimeter of the pec tendon to expose the latissimus. We then tag and release it. And this patient had previous surgery there, so there was some scar tissue here that we had to release. And we separate the latissimus tendon from the teres major, and we dissect the latissimus from proximal lateral to distal medial to get adequate excursion. And you can see after we've released the tendon here that there's good excursion of the latissimus. It is important to protect the radial nerve, which is on the anterior aspect of the latissimus distally. Then we anchor the latissimus down to the lesser tuberosity and use a couple anchors to bring it down. So a couple things, this is not a perfect procedure. If you look at the diagrams of how the latissimus inserts, optimally it would be here on the red surface where we get it past the bicipital groove and really get that internal rotation force. But oftentimes it's hard, even when you completely release the latissimus, to get it all the way up, higher up on the lesser tuberosity. The other downside is that if you've seen a subscapularis muscle and tendon, it is really beefy, and the latissimus, after you transfer it, admittedly is not as big as the subscapularis. And for this transfer, there's really not that much data on this currently, but in the data that has been reported so far, patients are seeing improvement in internal rotation and patient-reported outcomes with resolution of at least in this Korean study, of resolution of belly press in 18 of 24 patients. And then Dr. Elasan, who's done a lot of these, again, improvements in range of motion, pain, patient-reported outcome scores. But interestingly, when you look at the belly press test and liftoff tests, it's improved in the majority, but it's not completely resolved in most of them. And that may have something to do with the actual vector of the latissimus or the actual tendon, I guess, width of the transferred tendon. So again, looking at this algorithm, this is probably the hardest group to treat, the younger patient that's a little bit more active with a massive and irreparable cuff tear. So we've talked about partial repair, lower trapezius transfer, and latissimus dorsi transfer for irreparable subscap tear. So in patients that are not younger or a little bit more elderly and low demand, a reverse total shoulder is a totally reasonable option to consider here. So here's an example of a 78-year-old male that presented to me recently. He had a fall while hiking and has had pretty severe pain since that fall. And on exam in the clinic, he only had active forward elevation to 60, had a positive drop arm, positive stomach compression test. And he's been in physical therapy for 6 weeks and unfortunately has not been able to improve this. So he came to me wanting to get on the schedule to repair this cuff as soon as possible. The question is whether or not it's worth it to repair this acute tear in someone who has tried physical therapy but is still somewhat pseudoparalytic. So I'll make the argument here that if you compare cuff repair versus reverse shoulder replacement in the more elderly low demand patient, to me, there's very little question that the reverse total shoulder is probably the better way to go. The surgical time is less. So these days, with reverse total shoulders being more commonplace, the workflow's easier. We can get these surgeries done in about an hour, whereas repairing a massive cuff tear can take sometimes a couple hours to do. And surprisingly, with the reverse total shoulder replacement, even though it's a joint arthroplasty, many of these patients really have minimal pain in the post-op period. The time to functional recovery is very quick with the reverse total shoulder replacement, and there's really no dependence on soft tissue healing, so you don't have to worry about them being immobilized for a couple months for something to heal down. And currently, with modern day reverse shoulder arthroplasty, the complication rate is really low, and we worry about dislocation and component failure, but with common prostheses these days, it's not that common to have a complication related to that. I would say that the complication types are probably worse with the reverse total shoulder. We always have to worry about acromial stress fractures, which is happens in about 3 to 4% of patients with reverse shoulder arthroplasty, and that's not something that you would see with a cuff repair. So in terms of complication types, maybe not as bad with the cuff repair, but the overall recovery with the reverse total shoulder replacement is generally much better. So if you look at the early data on reverse shoulder arthroplasty for irreparable cuff tear, so this was Dr. Frankel's data and looking at 60 patients with cuff tearing and no glenohumeral arthritis, definitely saw some functional improvement, but very high complication rate of 20%. And a lot of this was related to glenoid base plate complications, dislocations, acromial and scapular fractures. And Christian Gerber also around the same time reported on results from 5 to 15 years using the reverse shoulder and for irreparable cuff tears, and found significant functional improvements, but a really high complication rate of 37.5%. So that's not something that a number that we're okay with. But if you look at the more current data on reverse shoulder arthroplasty using contemporary prostheses and the fact that we're doing so many more of these reverse shoulder arthroplasties, the complication rate is actually very low these days, and the survivorship is actually quite good. So this is a 10+ year follow-up, and we're looking at probably more than 90% survival rate of these implants. So in this patient with acute massive tear, 78-year-old, even though this is an acute tear and you may think that this is someone who might need a repair, in someone that's a little bit lower demand and elderly, a reverse total shoulder can be a very quick recovery. And this patient at 2 weeks had minimal pain, was weaning out of the sling, and by 6 weeks had no pain and good elevation and function. So to review here, looking at this algorithm here, just to summarize, in patients that, in almost all patients, we try some activity modification and physical therapy, and many of the patients may do fine without any kind of surgery at all. For those that have arthritis, we're definitely looking at shoulder arthroplasty. If they're well compensated, you could consider a CTA hemiarthroplasty, or if they're not and they have pseudoparalysis, then we consider a reverse total shoulder. For patients with no arthritis and they have a well compensated their function and they have an intact CA arch, we consider the smooth and move procedure, or what others term as a reverse subacromial decompression. And then this is probably the most challenging group of patients that are younger and higher activity level. If they have more of an acute on chronic tear, we may consider a partial repair. For those that are chronic and have a posterior superior repair, we're looking at lower trapezius transfer. And then for irreparable subscap, we're looking at latissimus transfer. And then for those with no arthritis and a massive cuff tear that really don't have great demands on their shoulder and a little bit more elderly, the reverse total shoulder is commonplace these days and can get very good results. Thank you.
Jason and Jay, this is Howard, and I have a question. And before I get to it, that was just an incredible grand rounds. Thank you to both of you. My question is, Jason, that as a non-shoulder surgeon, what seems to be catching my attention in my inbox and in the journals are references to using different biomaterials to aid in the repair of these massive cuff tears. And of course, I'm very skeptical when I see those. And I noted that you really just glanced over that whole issue in your talk, and I was interested in what your thoughts are on those.
So I went over a little bit with the superior capsular reconstruction, and then there are some newer devices these days where, because we're worried about the tendon quality of many of these patients that we're doing cuff repairs on, a lot of people are using dermal allograft or some other device to try to help to maintain that cuff repair. And actually that subacromial balloon is actually being used to help to kind of supplement and hold down a cuff repair. I think the data out there right now is not there at all, actually. So I don't have any experience with it. I think that in the next 5 or 10 years there might be some improvement or some data that we get out of it. So me and Albert in residency both were working in labs looking at other ways to recreate tendon and somehow maybe use biologic augmentation to span between the rotator cuff and the tuberosity. But it's really hard to mimic native tendon and get it to heal and function well. So there's really not great data on there. Maybe in the next 5 to 10 years that might come up.
And one other question, does the interpositional balloon work by maintaining the center of rotation of the glenohumeral joint?
Well, it's in some ways you have to have an intact anterior and posterior cuff to, that force couple to keep the glenohumeral joint stable. And then the goal is with that procedure is that the subacromial balloon would depress the humeral head and kind of restore more normal kinematics of the shoulder. Because if you have a large tear and you're not compensating well, the thought is that when you try to elevate your shoulder, there's nothing depressing the humeral head. And by depressing the humeral head with the spacer, you may be able to restore some kinematics to allow for better motion. So there have been some preliminary studies on that, but nothing again showing that it's any better than just doing a debridement procedure.
The balloon is kind of interesting in the sense that I think that, like you mentioned, Jason, it's made of a biodegradable polymer. I think it goes away after like a month or two.
Yeah, so the thought is that over the course of a few months or a year that the PLLA balloon will kind of just go away. And I think whenever we're talking about anything that you're putting in a joint or in the body that degrades, you always have some concern. And so when we were originally using PLL anchors in the shoulder for glenoids or rotator cuffs, we saw a lot of problems with synovitis and that type of thing. So it'll be interesting to see when, this is definitely going to be something kind of hot in the next 5 years where a lot of people are going to start using it. And we really need to, do good studies on comparing something like the subacromial balloon to something like a simple procedure like the smooth and move, just to see if really that there's value in using that device.
Anybody have any other questions? Okay, Albert, thank you for introducing Grand Rounds. And as everybody knows, we typically skip August for Grand Rounds. So have a great summer if I don't see you, and see you at our Grand Rounds the first week of September. And thank you again, Jay and Jason. That was really wonderful.
Thank you.
Thanks, everyone.
Have a great day, everybody.
Recording stopped.